Unit 12 is abnormal psychology, or studying the various categories and classifications of psychological disorders according to the diagnostic criteria in the DSM-5. So to get into the categories of disorders, you first have to consider what makes something a psychological disorder as opposed to just a deviant trait or a behavior that someone may possess or someone may have. For it to be considered something that is a disorder, the typical diagnostic rule of thumb is the 3Ds, whether it's a deviant behavior that is something that is outside of one's culture, combined with the fact that it is dysfunctional or disruptive to one's life to the point of being distressful. There's other criteria that you could put in with that. Obviously, there's a lot of gray area as some controversy stems from psychological disorders where people may have personality disorders, for instance, and not necessarily find their traits problematic. It may not be distressful to them. At what point does someone who is not distressed by their behavioral habits or patterns, do they still fall into that category or that diagnosis of being disordered? And I guess the caveat to that would be if it's something that's clearly harmful to others. So the criteria for someone having a behavior or a trait is very different than someone possessing a disorder. For instance, to give an example, it is one thing to suffer from a bout of anxiety. It is another thing entirely to have a distressful and dysfunctional level of anxiety on a regular basis, or the same thing is true with depression. It is one thing to be depressed, it's an entirely different thing to have depression. As far as diagnosing psychological disorder or abnormal behaviors, it's definitely come a long way from the sort of archaic origins of misunderstandings and taboo behind disordered behavior. And there's pros and cons to that. The addition of the medical model is the idea that, very similar to biological health, that psychological disorders should be treated as if they were health issues, mental health issues, so they can be diagnosed and they can be treated. And that would be the goal of treatment, whether it's therapy or pharmacology, is to cure the patient or to get them better. The downside to this, obviously, is it has led to an increase in prescription medication, psychopharmacology. It's also led to an increase in the diagnosis of psychological disorder. There's a massive increase in people having diagnosed disorders, even young children having diagnosed disorders, and so there are pros and cons to the medical model, but it's definitely a different approach than the initial way that psychological disorder was viewed by typical Western societies. You would see people that were locked up in straitjackets in padded rooms, or just sort of removed from society as a result of what was something that now would be considered diagnosable, treatable, or even curable. That people can manage their symptoms, that they can get treatment, and that they can live a functional life. Again, this has led to the the medical model led to the creation of a diagnostic criteria. And that diagnostic criteria is laid out in descriptive categories in the 5th edition of the DSM. The DSM is the American Psychiatric Association's Diagnostic Statistic Manual of Disorders, and currently we are in the 5th printing or edition of that, which was released in 2013. And that is the criteria that's used by psychiatrists and psychologists to diagnose their patients. To get into just the categories of disorders, in no particular order, we have anxiety disorders. Anxiety disorders are a broad spectrum of disorders, and to understand anxiety, you have to kind of differentiate what the term anxiety refers to. It's sympathetic nervous arousal that has to do with fight or flight, but essentially hormonally it is stress, cortisol and adrenaline in the blood, norepinephrine from the brain, So anxiety is essentially a synonym for stress. It is the anticipation of a potential outcome. It is the lack of control over that outcome. And so in that regard, it makes it easier to understand how various anxiety disorders manifest themselves. For instance, generalized anxiety is what people typically think of with anxiety disorders, where a patient or a person may suffer from random bouts of anxiety that have no particular trigger or cue, and they may just be high-strung neurotic people that have a difficult time navigating the day-to-day routines of their life. But that's very different than something that has a specific trigger, like a specific anxiety, whether it's a social anxiety or a specific phobia. And then you even get things like anxiety behaviors or behaviors that are enacted as a way to ward off anxiety. So things like obsessive compulsive behaviors. People participate in rituals until they feel satisfied that they have completed, or that they have satisfied their desire, whatever urge it is that they feel compelled to act on. Otherwise, they will have an anxiety almost to the level of panic. They will have an anxiety attack because they haven't completely satisfied that desire, that drive in their brain. So even things that are disorders that are marked by anxiety reducing behaviors, like obsessive compulsive disorder, are still considered anxiety disorders, because the purpose for the compulsive behavior is to ward off or to satisfy the obsession. So the obsession is the thought, the compulsion is the behavior itself. Then you have other more specific acute anxiety categories like panic attacks or panic disorder. People who suffer from panic disorder have random bouts of panic attacks that are very similar to, essentially they are nervous breakdowns that are very similar to somatic symptoms of hypertension, tightness in the chest, difficulty breathing, blood pressure spikes. So it's very much a biological and medical symptom that comes with having a panic attack, which can be debilitating for people, and also they tend to fear and the oncoming panic or anxiety, and so that might make them apprehensive to participate in certain behaviors or activities because of the fear of the anxiety coming back. And then of course you have specific phobias, and phobias are different than fears, because fears are biologically rational, meaning that they are a fear of something that poses a legitimate threat of bodily harm or even death. A phobia is something that is probably conditioned or learned, going back to John Watson and behaviorism and the phobias which were irrational that he conditioned into baby Albert. So it kind of flies in the face of the Freudian idea or psychoanalytic idea that phobias are something that is subconscious or maybe repressed trauma from childhood. So people would be afraid of dogs even if they have no actual concrete memory of an episode in which they were attacked by a dog. So that would be the psychoanalytic view of phobias, where the behaviorist view of phobias would be that it's something that is environmental. It's nurtured into someone from experience. And so regardless of the source of the phobia, it's considered an irrational fear because it's something that doesn't actually pose a biological threat to one's safety. Again, there's a separate category for obsessive compulsive disorders. In the DSM-5, it has its own cluster of diagnoses, and again, it's repetitive obsessive thoughts, what's sometimes referred to as rumination, and the compulsion is the action that is really compelled to satisfy the obsession so that people can move on in their day to normal day-to-day activities. So obviously suffering from OCD can be somewhat debilitating and cause people to have a hard time functioning from day to day, because they become so wrapped up in compulsive behaviors because they are trying to satisfy the obsessions that they have in their brain that they can't seem to satisfy. PTSD is really not something that is specific to violence. Many people think of PTSD as being related to combat or related to a car accident or related to an attack of some type, and it certainly is that. But post-traumatic stress can be from any trauma. Emotional trauma can be as debilitating and damaging as physical trauma, and so PTSD is the official term in the DSM-5. It was a previously diagnosed but understudied and misunderstood psychological disorder that was in the days of Freudian psychoanalytics was referred to as shell shock. But again, what it is it is a stress trigger that's tied to a painful memory or an emotionally intense memory. What we know from Chapter 7 is a flashbulb memory. And flashbulb memories, obviously being very emotional, your brain tends to sear the details of those things, which evolutionary psychologists would point to as an adaptive trait to prevent you from going into that situation again. But regardless, again, it's clear that people suffer from residual emotional trauma from events that have happened in the past, and some people have a hard time moving on from those things. Phobias and post-traumatic stress, emotional disorders that are related to anxiety, the best way to treat those anxiety disorders is with cognitive behavioral therapy, which is not the same approach that you would use for depression. To get into another category, what used to be known as somatoform disorders, these are somatic symptom disorders. Remember, the term soma refers to body, something having to do with an actual biological symptom in the body. And this is a unique phenomenon that's a little bit less common than anxiety disorders, but this is a symptom that originates from something psychological that causes a bodily or somatic symptom. I mean, to use the same word again, it is a physical symptom that stems from a psychological source, would be the best way to put that. So really, to look at it in two different ways, you have somatic symptom disorder, you have something that refers to a physical symptom that is related to the psychological stimulus. So for instance, if you have let's say you have a panic attack in your brain, or panic in your brain, a high level of stress, that can manifest itself in your blood pressure. It can manifest yourself as hypertension. It can show up as a related bodily symptom. Conversion disorders are different. Conversion disorders are symptoms that affect the body that don't seem to have a physiological cause, right? So for instance, people who lose their hair in bouts of stress, or people who have rashes that pop up on their skin, people that temporarily lose their eyesight, or people who may have ringing in their ears. These are symptoms that don't really have a biological cause or function, but they have a psychological cause or function. So again, a conversion disorder is something that stems from the mind, but causes what seems like an unrelated bodily symptom. And a somatic disorder is something that is somewhat explainable or attributable to a psychological disorder. And looking at the slide, there's a problematic way that this is typed. Somatic symptom disorder, it says, is formally called hypochondriasis. That's actually something that's referred to as illness anxiety disorder. Illness anxiety disorder is the DSM-5 classification for what we used to refer to as hypochondriasis. And so people would use the phrase or term, that person is a hypochondriac, meaning that they misconstrue or misinterpret symptoms. So this is actually not a correct thing that's typed on the screen there. It's probably a typo, but that's illness anxiety disorder when you look at something like the example they give where you have a bruise on your leg and you misconstrue that to be cancer of the bone, or you massively overestimate what it is that your symptoms are from, what the cause of your symptoms are. So somatic symptom disorders are a lot less complicated than that. That's actually the definition of illness anxiety disorder. Somatic symptom disorder or somatoform disorders are physical reactions to psychological problems, and they actually make physiological or medical sense. Biological sense, I should say. Conversion disorders are things that happen on the body that really don't seem to have an attributable psychological cause. For instance, the example of losing one's hair, there's really not anything that would explain how the hair follicle would be affected by something that's inside your mind. So therefore the term conversion, it's some psychological stress that's so intense that it somehow converts into a completely unrelated physical form. Then we get into a category that's strange and controversial. It has to do with a split in your awareness or your conscious mind. These are known as dissociative disorders. Dissociative disorders are represented usually by some type of amnesia or a dissociative state that's known as a fugue state. Dissociative disorders are usually environmentally stimulated from previous trauma. They certainly include split personality disorder, or what is officially known as dissociative identity disorder, which is controversial in its own right. But dissociation disorders have to do with the preconscious mind's either inability to cope with its environment or its defense mechanism, to use a Freudian word, of the trauma that it has experienced. So for whatever reason that they take place, the patient who suffers from a dissociative state may find themselves in a location that they have no recollection of how they got there. They may have committed an act of violence or committed a random behavior without having any memory that they did it, which obviously they clearly did. And so this is almost like the brain being on autopilot without a conscious awareness of what the body is doing. And so there's something in the implicit centers and subconscious centers of the mind that's driving a behavior, but there's no conscious frontal lobe awareness of it, which again, we have a dual processed or dual track mind. We have a conscious awareness of ourself and what we're doing in relation to the stimulus around us, but we also do have a subconscious mind, and the subconscious mind sometimes is undervalued or devalued until you see things like dissociative disorders, which really point to the power of the unconscious, because there are things that we can do that are almost, to use Freud's term, deterministic, things that are determined by an unconscious force that we may not necessarily be in control of. And so in deep psychological states of stress, someone might form a dissociative state or a dissociative separation in their memories or thoughts. And it could be some kind of emotional defense mechanism. But it is rare. It's difficult to diagnose. Because again, it has to do with a split in one's consciousness where their actions and behaviors are one thing and their conscious awareness is something else, or is somewhere else, for lack of a better term. Now, mood disorders are a little bit different. These are the serotonin disorders that can be anywhere on the spectrum of emotional either overload or underload. So if you look at the highest level of serotonin as being a manic state and the lowest level of serotonin as being a depressive state, then you get what was previously known as manic depressive disorder. People whose serotonin systems fluctuate so often and so much that they will go from a high manic state where they cannot feel upset, they have inappropriate emotional responses, even if something bad or negative or scary happens. They have unusual energy. They are hyperactive and can't settle themselves and calm down. They are emotionally and mentally scattered. They are very motivated and just almost dysfunctionally happy to the point of being inappropriately just being inappropriately in a level of emotion that becomes destructive. And the thing about bipolar disorder, as opposed to just being manic or just being depressed, is that the brain's serotonin system in someone with bipolar 1 alternates between the two, and you fluctuate throughout the course of the day from the emotional highs of being manic to the hopelessness and despair of being depressed. So bipolar 1 and to a lesser degree bipolar 2 are mood fluctuations and swings to the extremes of the polar opposites, and can happen within a matter of hours or even minutes. Now, major depressive disorder is a lot more common. Although bipolar 1 is fairly common in the United States, it is a high diagnosis, especially among adults, but it is treated in a similar way as depression. It is treated with SSRIs, which are selective serotonin reuptake inhibitors, essentially things like Zoloft, Lexapro, and those are drugs that will block the reuptake of serotonin and thus manage the level of serotonin in the synapses of the serotonic pathway. So people who suffer from depression may have suicidal ideation, they may have lethargy, they may have a lack of motivation, they may feel hopeless and helpless, they may not get up off of the couch for days or weeks at a time, they may lose interest in things that they previously enjoyed doing. And these things are all characteristic of people with major depressive disorder. And according to the DSM criteria, major depressive disorder is diagnosable only after 2 weeks of consecutive symptoms. And usually you would treat these in the immediate meantime with SSRIs, and you would couple that with therapy, hopefully, to help people cope with their depression and gain perspective, and exercises to hopefully increase their serotonin levels a little more naturally. So schizophrenia disorders are similar to dissociative type disorders. In fact, a lot of times you see an overlap between schizophrenic disorders and schizophrenic disorders and personality disorders, and sometimes you see an overlap with schizotype or schizophrenic disorders as being a dissociative disorder or some type of dissociative state. So previously, it was very common for people to mistakenly refer to multiple personality disorders, or what is now known as dissociative identity disorder, for people to refer to that as schizophrenia. So multiple personalities or dissociative states are not necessarily indicative of schizophrenia. Schizophrenia is in a specific part of the brain that deals with delusions, meaning in the literal sense the inability of the brain to differentiate thought, memory, fantasy with reality. And so people with schizophrenia have a difficult time separating fantasy from reality, and their brain just can't seem to determine that switch between the thought processes, or what we would just normally think of as an inner monologue. So some people with various types of schizophrenia can suffer from a multitude of symptoms. There's schizophrenic personality disorders, schizotypal disorders. You can have catatonic schizophrenia, and that's where people go to a state of catatonia where they are essentially almost in a vegetative state. And it's difficult to even know if it's like a lucid dream, because they may be in a coma-like state, and that would look very dissociative, where their body is obviously alive and functioning, but their mind is completely unconscious. It's not responding to external stimuli like sounds or sights, and people don't have memories of things that happen from their catatonic states. Now, most people with catatonic schizophrenia, unlike regular dissociative disorders, the catatonia can happen for a very short period of time. It can happen in the middle of a sentence and last for a few seconds, or it can even take on the form of just mindless, subconscious, implicit mimicking of words, which are not actual thought processes. They are just subconscious, implicit responses, almost like a parrot-like repetition. So there's different types of catatonia, and it is rare and it is extreme. Most schizophrenia is some kind of disorganized speech, some kind of emotional inappropriate response, and usually it's some level of delusion. It can be paranoid. Paranoid schizophrenia is a debilitating type of schizophrenia where people believe that they are in danger, or they believe that they are someone famous, or they have beliefs that are delusional in a literal sense. In some cases, paranoid schizophrenics can have both delusions and hallucinations. And hallucinations are different than delusions in the sense that they are things that you hear, which would be auditory hallucinations, things that you hear that are not really sound decibels in the air, like voices, or they can be things that you see. Sometimes people with paranoid schizophrenia will see people that are not there, and those are hallucinations. But some paranoid schizophrenics do not see things. They may actually just believe things that are not true, and that would be a narrative that they believe rather than something that they hear or that they see. Personality disorders are a little bit more rare, unlike, say, mood disorders or schizophrenic disorders, which are genetic. They are the only two categories of disorder that span culture and time. In fact, many of the environmental disorders like anxiety disorders or personality disorders, you only see those in certain cultures, developed cultures and developed nations, as they are quote-unquote first world problems, so they are largely environmental. The thought process or research that someone could be born as a psychopath, meaning someone who is destructively violent to the level of being a serial killer, is really inconclusive. There's a narrative that people sort of pass off as fact, as if there's been a genetic marker discovered, i.e. the serial killer gene, and that's just not a scientific fact. There's probably a genetic component to the things that need to be present for someone who is a violent killer or a violent offender or a manipulator, but in the case of personality disorders, they are almost completely environmental. It is a very rare scenario for someone to be born with the underdevelopment in the frontal lobe, which would prevent them from having empathy. That's about 1% of the U.S. population by most research calculations, and even in addition to that, if it is 1% of the population that would be born with psychopathic tendencies, that still does not indicate that they would have anything that would make them be more violent or less violent than the next person. So there's still an environmental factor to what makes people violent, or what makes them motivated to harm other people. So when we look at personality disorders, they can range from things like narcissism, which is the disregard for the concerns of others, or the unknowing, unrealizing that someone is manipulating others for their own benefit or gain. And so narcissistic personality disorder is fairly common. It's usually in men. It's about 50 to 70% male in adulthood to be diagnosed as a narcissist. You get other personality disorders like histrionic disorder. You get borderline personality disorder, which deals more along the lines of interpersonal relationships, people who sabotage relationships that otherwise would be healthy, or they push people away subconsciously, and maybe that can be coupled with some level of depression or some level of bipolar mood swings. But borderline personality disorder is specifically categorized as being relational, whereas antisocial personality disorder is usually what people think of when they think of sociopathy. So someone who has impaired social functioning, they have a severe actual neurological lack of empathy in the mirror neuron center of the frontal lobe, so they don't feel empathetic towards a victim. They also don't have much of an emotional connection even to immediate family members. It's not that they're incapable of connecting or loving with people, but that they would not feel the guilt or the emotional trauma from harming someone close to them. So what people would typically refer to as sociopathy or being a sociopath is really what is diagnosed in the DSM as being antisocial personality disorder, and it is 75% male. An antisocial personality disorder is much more destructive than narcissism because it shows warning signs very early on, as young as 8, and definitely usually by 15. Violent tendencies, obsession with the macabre, especially harming animals or torturing animals, inflicting pain on themselves or on others out of a morbid curiosity, and then manipulation, cheating and lying, fighting, other risky behaviors like addiction, uninhibited sexual practices, and things like that. So in some ways, antisocial personality disorder shows a lot of the same symptoms as narcissism, but is much more destructive. It is much more uniquely male, and it is much more potentially harmful to society. So you can see that list there on the right of the screen. It says respectless, failure to conform to social norms with respect to lawful behaviors, as indicated by repeatedly performing acts that are grounds for arrest. That is one criteria for antisocial personality disorder. Being deceitful, as indicated by repeated lying, uses of aliases, or conning others for personal profit or pleasure. Being impulsive, that is something that's somewhat unique to antisocial people with antisocial disorder that may not necessarily exist in narcissism, is the impulsivity. Also the aggression. Aggression is a very strong symptom and red flag in someone who may potentially be antisocial. You don't see the same level of aggressiveness and irritability and rage or even physical harm or violence in someone who's narcissistic. So you would get the level of emotional control or psychological abuse, maybe even gaslighting or something to that effect. Somebody who is taking advantage of someone else for their own personal gain, but not necessarily to the level of aggression and violence of being antisocial. Another unique characteristic of being antisocial as opposed to being narcissistic is being reckless, not only for the safety of others, but the safety of themselves. Someone who is narcissistic may actually be the opposite of that. They may be completely self-serving and do anything to protect themselves, and care a lot more about the outcomes of what happens to them, where somebody who is antisocial may not. They may not care as much about what happens to them. They may not be as protective for their own self-interest. They might be more impulsive and reckless, almost violently curious about certain things. They're more likely to harm themselves. They're more likely to get into trouble in school. Irresponsible. Consistent irresponsibility is indicated by repeated failure to sustain consistent work, behavior, or honor financial obligations. Again, this is something that is unique and antisocial that doesn't exist necessarily with people as a symptom of narcissism. And of course, remorseless. Complete lack of remorse as indicated by being indifferent or even rationalizing having hurt, mistreated, or stolen from someone else. So that's it for chapter 12. In the next video we will get into kind of the second half of this. Unit 13 goes in conjunction with Unit 12 because it is the treatment practices for psychological disorders. So in Unit 13 we'll get into the various ways that mental health professionals and psychiatrists will treat these various disorders.